Greetings from Indian Journal of Anaesthesia. I, Dr. Kushbu Pandey, will be presenting an original article from June issue of Indian Journal of Anaesthesia. Incidence of acute kidney injury and its associated risk factors in patients undergoing elective oesophagectomy surgeries at a tertiary care cancer institute, a pilot prospective observational study. Major complications after oesophagectomy are common, despite improvements in surgical techniques and post-operative care. Of these, acute kidney injury is a potentially hazardous complication. Various perioperative factors associated with esophageal cancers and surgery predispose the patient to develop post-operative AKI. However, little is known about the incidence of AKI following oesophagectomy in Indian population. The reported incidence of AKI in the published literature varies widely between 2.4% and 35.3% across the world. The reasons for wide variations could be heterogeneous populations, different practices of food administration, and differences in the criteria used to diagnose AKI. Hence, the authors conducted a prospective observational study to determine the incidence of AKI in patients undergoing elective oesophagectomy as a primary objective. The secondary objective were to identify the risk factors for the development of AKI and its effect on perioperative outcomes, that is, duration of post-operative hospital stay and in-hospital mortality. Out of 258 eligible patients, 58 patients were missed when the study was halted. Therefore, 200 patients were included in the study, and only 183 patients could be considered for analysis, as 17 patients, out of 17 patients, 16 patients were inoperable, and one patient died within 72 hours of the surgery. The study was approved from the Institutional Ethics Committee and it was registered under CTRI. It was a prospective observational study where participants undergoing elective oesophagectomy surgeries were included, whereas patients with preoperative chronic renal insufficiency, as diagnosed by serum creatinine of more than 1.5 milligrams per deciliter, patients with a history of AKI, and patients with a history of receiving renal replacement therapy were excluded from the study. Standard anesthesia and monitoring was instituted for all patients in the operation theatre. Post-operatively, the patients were nursed in the recovery ward or intensive care unit for up to 24 hours. Acute post-operative pain was managed by a dedicated acute pain service team, which followed standard protocols to offer multimodal analgesia. The occurrence of AKI following oesophagectomy was identified according to the kidney disease improving global outcome criteria, that is, HITCO criteria. Accordingly, serum creatinine values were assessed on post-operative days 1, 3, 7, 15, or the day of discharge, and on the day of first outpatient clinic follow-up, or day 28, whichever was later. The occurrence of post-operative complications was noted daily by the member of the study team until the time of discharge from the hospital or death of the patient. The length of ICU and hospital stay and post-operative outcomes were noted. These are the demographic details of the patient recruited into the study. Of the 183 patients, 27 patients, that is 14.7%, developed AKI in the post-operative study. Out of these, 15 had stage 1 AKI, 7 patients had stage 2 AKI, and 5 patients had stage 3 AKI. The mean duration of hospital stay was significantly prolonged in patients with AKI, that is 13 days versus 9 days in those without AKI. The in-hospital mortality rate was significantly higher in patients with AKI compared to those without AKI, which was 14.8% versus 1.3%. Among the perioperative factors, following variables were significantly associated with the incidence of AKI, and a multivariate logistic regression analysis was performed for them. So here we have the table where the association of perioperative factors with incidence of AKI was noted, and we can see that the highlighted perioperative factors were significantly associated with the incidence of AKI as depicted by their mean values p-values being less than 0.05. These factors were ECOG, age, preoperative albumin, intraoperative use of vasopressors, total blood loss, postoperative use of vasopressors, mechanical ventilation, postoperative pulmonary complications, arrhythmias, anastomotic leave, use of contrast enhanced CT scan in the postoperative period, and exploration under general anesthesia in the postoperative period. After multiple imputations, three independent predictors of AKI were identified, that is age, use of vasopressors in the postoperative period, and occurrence of anastomotic leave. An ROC curve was plotted to know the goodness of the fit of the multivariate model, and the AOC, that is area under curve of the model, was 0.789. In this prospective observational study, the incidence of AKI in the patients undergoing elective oesophagectomy surgery was 14.7%. Higher age, postoperative use of vasopressors, and occurrence of anastomotic leave were independent predictors of AKI. Postoperative AKI was associated with higher in-hospital mortality and length of hospital stay. Another important finding of the study was that AKI was significantly associated with postoperative pulmonary complications and interventions as well. Postoperative complications following esophagectomy often have multisystemic involvement. These complications lead to systemic inflammation, hemodynamic instabilities, and often hypoperfusion. Nephrotoxicity occurs due to long period of hypoperfusion and exposure to contrast dye and antibiotics. The study had strength that it is one of the novel prospective studies to determine incidence of AKI and its associated risk factors in the esophageal surgery. Whereas, as a limitation, the study was conducted at a single center. It only involved 1 month follow-up after the surgery, and novel biomarkers were not used to assess AKI. As a conclusion, the incidence of AKI following esophagectomy surgery was 14.7%. Age, postoperative anastomotic leak, and requirement of vasopressors in the postoperative period were the independent risk factors for development of AKI. And AKI was significantly associated with prolonged hospital stay and in-hospital mortality following esophagectomy. Thank you.